Welcome. I'm Dr. Kristen Eckstrand, a fourth-year medical student at the Vanderbilt University Medical Center and co-director of the Vanderbilt Program for LGBTI Health. I'm here today with Dr. Jamie Feldman, Associate Professor in the Department of Family Medicine and Community Health and faculty in the Program of Human Sexuality at the University of Minnesota. Dr. Feldman, thank you for being with us today.
My pleasure.
Dr. Feldman, can you explain what is gender identity and how does that develop and change over time?
Gender identity is the sense of one's internal sense of gender, of who one is on the masculine, feminine, gendered spectrum. And we're really learning about this more and more as scientists over the years. So that when we think about sex in terms of a physiologic characteristic, Y chromosome, genitalia, et cetera, some people will experience a discrepancy between how their body is built, that is genitalia, hormones as producing in the body, X or Y chromosome, and their internal sense of felt gender. And that internal sense of felt gender may be more masculine, more feminine, neither or both along a spectrum.
And in terms of the clinical environment, what terms are frequently used to describe gender identity, both within the LGBT community, and how does that translate into the clinical situation?
There are probably as many terms to describe gender identity as there are, maybe slightly less than there are human beings to describe them. And these terms are more or less acceptable to various people, and they've evolved over time historically. Terms that are commonly used are transsexual. That has been often used, particularly historically, to describe someone who has wanted to transition from their gender as assigned at birth to the very, quote, opposite gender, male-bodied to female-bodied, as much as possible with hormones and surgery. Transgender has been an umbrella term, usually to describe anyone who feels of one gender assigned at birth towards a different gender. Female to male, male to female, transmasculine, transfeminine, genderqueer, meaning different from along a spectrum from one gender to another without necessarily defining what that gender is. And the list goes on and on, drag queen, drag king, a whole host that I could probably come up with 500 or 600 terms. The best way to handle terminology is to ask your patient to become familiar with those terms in the literature that are reasonably accepted nowadays: trans man, trans woman, genderqueer, and then pick one to start with, and then ask your patient first, pick one to start with, ask forgiveness, and move on if you get it wrong.
So it sounds like there's the terminology that you use to respect the patient, and then the clinical context in which they're seeing you, which may or may not be related to gender and transition.
Right.
Yeah.
So if a patient presents in a purely masculine fashion, and you're asking, and their name is Bill, and they present looking like a masculine person, and you say, "How would you like me to address you?" Go from there.
And historically speaking, how have transgender individuals been treated within healthcare, and how has that changed over time?
Historically speaking, transgender individuals have been treated incredibly poorly by the medical profession. And this is a reflection, generally speaking, of society at large. And I'm going to stick mainly to a Western biomedical perspective. I'm not going to speak for other cultures. Mainly because it's a stigmatized population. We don't like when people in our society transgress boundaries. Masculine, feminine boundaries, boundaries of gender, boundaries of sexual orientation are pretty hard and firm in our societies, and we don't like people crossing them. There are general norms that we don't like things to get messed up. And that's one that's been very typical. And so people tend to hide them. When people transgress those boundaries, and particularly ask for medical intervention to move across those boundaries, the people are seen as either morally deficient, mentally deficient, or mentally ill, or somewhere along all three. And they're often turned away, refused service, or incarcerated in some fashion. And that's been the history of it. Over time, that has evolved to gender dysphoria being seen as a medical concern. And this has been improving to a great extent. It's still a great controversy. It's still difficult to access. It's still very variable across, particularly the U.S., in terms of ability to economically and physically access intervention.
So it sounds like there are a number of disparities in accessing care. Are there also disparities in health outcomes for transgender patients?
Very much so. So any number of studies have shown a great deal of difference in health disparities. Those disparities vary depending on what kind of outcome you're looking for. So there's a great deal of difference in terms of smoking, substance use, depression and suicidality particularly are quite high among this population. The rate of mental illness, if you take mental illness as a whole, like bipolar disorder, schizophrenia, is not necessarily high, but the rate of depression is. This is felt due to the stigma associated with it and living in a world where they feel they have a great deal of barrier to health and living with gender dysphoria. Unsafe sex. That can be variable depending on whether we're talking about trans men, trans women, people of color as well as transgender. In terms of medical health outcomes, you have a very high rate of uninsured or underinsured people. We talked about smoking. There's some suggestion, of course, higher rates of poor health outcomes in things like cardiovascular disease, other illnesses, and we're not sure if that's due to increased risk factors or simple lack of access to care due to lack of health insurance, which is also quite high.
So how can a provider make their clinic a more welcoming environment for transgender patients?
It's sort of take it from the top. If you want to make your clinic an environment that's welcoming, you have to start from walking in the door. You need to educate your front desk staff. You need to educate your nursing and CMA staff. Proper medical records, proper pronouns. How do you address people? How do you welcome people? Bathrooms. If you have segregated bathrooms, you're automatically forcing people to kind of make a choice. Well, if I'm presenting feminine, but I haven't fully transitioned and I don't have my papers saying I'm female, and I walk into the female bathroom, am I going to be arrested? Is there going to be shouting, shrieking, gnashing of teeth? Or can I have unisex bathrooms here, a family bathroom? So that's the major piece of it, educating providers. If you can do transgender-specific medicine in your clinic, or if you can't, meaning providing hormones, accessing mental health services that are trans-appropriate, can you have resources available that people can be referred to? Knowing how to have an electronic medical record that is appropriate to people with all sorts of body parts, and not divided simply into this is the male exam, and that all men have prostates and all women have breasts. Can you have something that says female and still have a penis on it?
So that's really wonderful information. What other resources are out there for health professionals to better understand the health needs of transgender patients?
Oh, I'm so glad you asked, because there didn't used to be so much, and now there's just been an explosion of great resources out there. The WPATH Standards of Care 7 now has a lot of information about the health needs and emotional needs, and standards of care for treating trans folks. The Endocrine Society guidelines are there with evidence-based care for endocrine care for trans people. Principles of transgender medicine and surgery, including primary care. The Fenway Guide is a great guide. They're just coming out with a second edition, which includes a lot of primary care for trans folks. Even though it's mainly Canadian-based, it's really straightforward and easy to read. Vancouver's guidelines on trans care, both hormone therapy, psychosocial care, and primary care. So there's a ton of basic, easy to read, very thorough material, helpful for providers out there in the community. There's now good material also now on adolescent youth, trans youth, that is really coming out there both in the U.S. and from the Netherlands. And so I encourage providers to get their hands on it, because they don't just have to call me. They can now actually just flip to the book and get some basic information answered.
Yeah, it sounds like there actually has been quite a bit of information that's been published. How has that been translated into the medical school setting for students?
Very little, unfortunately. Because a lot of this is within the last 5 years, medical schools tend to run very slowly. It's like turning the Titanic. So incorporating that new information into curricula, particularly as reference pieces, has been quite slow. Mainly because of competing strategies, competing priorities, that heart guidelines tend to get incorporated first, like, oh, how do we treat cholesterol gets incorporated first before how do we better treat trans patients. But ultimately, I think medical schools will catch up, especially since this is a very hot topic. There are guidelines from all of the new professional organizations, ACOG, AAFP, really calling for appropriate education and service to this population. And so it's really a demand on the medical schools to step up and put this care into their training.
Are you aware of any schools that have started to do things well related to teaching transgender health?
They're starting to. I can speak for my institution, the University of Minnesota. On the medical school level, the medical students are introduced to transgender medicine as part of their human sexuality course. And so they get introduced to the concept of the disparities that transgender populations face. They get introduced to a panel of transgender folks who talk about their experiences, their disparities, their health challenges, just their medical needs very early on in their training, as well as receiving lectures on transgender health. More importantly, in the clinical years, many of them do get exposed to transgender patients. Our family medicine residents are required to do a sexual medicine workshop, and they do get lectures on transgender medicine as well.
It sounds like at the University of Minnesota, you have done a great job of sort of integrating it into existing courses rather than creating a stand. Is that a strategy that you think is successful?
I think that's probably essential. Rather than making it some sort of special thing, it really should be integrated with maybe a little bit of a special extra on top, but it really should be part of how you do things. Since the transgender population is, depending where you live in the country, you may or may not knowingly meet many transgender people. So I think a panel, kind of an introduction and being kind of brought face to face with that population is really kind of required. So that special add-on, I think, is really essential. At the same time, kind of incorporating it as the normal part of doing things, that it's nothing special, that it's just expected of you, that it's not weird or exotic, just like that, treating women isn't weird or exotic, or treating people of color isn't weird or exotic. Treating transgender people shouldn't be weird or exotic. It's part of the routine of doing things. Is I think, an appropriate and successful approach.
So you mentioned that, again, whether or not you can get people to come in and demonstrate sort of their own experiences with living and being transgender. What would you say for schools who may be in settings where people may perceive it as being harder to build a panel? What are some other strategies that can be used to get content into medical education? So
video conferencing, so like a video panel, bringing some speakers in. So let's say I come from the upper Midwest, so let's say the medical school in South Dakota may not have, there's more transgender people than you think, so you may have to go to a few cities to get a panel of 5 trans people. But video conferencing, a panel in, having even 1 or 2 people that you meet physically is still very helpful. Having people rotate through another institution may be helpful. And then again, still incorporating the concept, the idea that, one, you may have met a trans person and not known it. Just because someone came in for a sore throat, you don't know that that person wasn't trans. It's not like they carry a big sign. So using I think video technology is really a great way to incorporate trans health as well. But the more you meet a human being face to face, the better.
Yeah. So it sounds like for something that medical schools could do is really start pointing students to places that would be able to provide more of that face-to-face, maybe during an elective course, something like that.
So and we get a fair number of people from the upper Midwest, or even I've gotten some students from the South as well.
Are there other places in the country that you feel provide those learning opportunities to get that clinical experience in addition to the University of Minnesota?
I know that Lyon Martin has a rotation out in San Francisco. I know that there probably. I don't know that Fenway Clinic does, but I imagine something could be arranged. So there are probably several opportunities that people can have. The more that it can be done not too far away, the better, but people can certainly do electives. The only problem with electives, and I love electives, is that it's sort of self-selecting. The people who most want to get that experience will get that experience, and the people who don't care one way or the other will never get the experience because it takes a lot of effort. So you want to get some exposure to all medical students. It doesn't have to be a lot, even just that one encounter of face-to-face. And so I think somehow we're going to be able to have to incorporate some face-to-face exposure with trans people kind of in medical school, and somehow. Whether that's, again, through a video panel or whether that's through actual human beings.
And in addition to that point about really getting a chance to interact with a patient who identifies as transgender, what are the other must-know things that medical students need to hear within the curriculum, even if they aren't self-selecting to go somewhere to get that?
Okay. I think that the thing that they must know is that, like anything else, trans care is not rocket science, meaning not everybody perhaps has to do hormone therapy. We all think about it. It was like HIV was. It's like, oh my God, there's an HIV patient in my, this is, speaking as a family physician, this is all I remember doing. Oh my God, there's an HIV patient. I can't care for them. Please send them away. It's like, they're just, they're getting their care elsewhere. They're just here for their, stubbed toe. You can take an x-ray. Don't freak out. Okay, the first thing is don't freak out. Okay? You don't have to be an expert in everything. You could. It's really not rocket science. It's not hard. But let's start at the basics. You're a family doctor. This is a patient. Learn to treat the patient. Patient like everybody else. So treat the patient. Second is, there's some basics that you need to know. It's not any harder than anything else that you need to do. here's the book, read, and we'll help you, okay? And then finally, if you want to do hormone therapy and you can learn to do hormone therapy, you should learn something about it. Just like you learn about heart failure, you learn about diabetes, you learn about anything else. All physicians probably should know something about transgender-specific medicine a little bit. Even if you're not going to do transition-specific kind of medicine, you should know a little bit something about it so that when someone walks in the door, you're not an uneducated provider, okay? And be able to provide reasonable care. And we do this it's not that much different from anything else that we do, okay? It's not out of the realm of a lot of stuff. So despite the fact that it seems exotic or strange, that's the first thing that people get that feeling of this is weird. It just isn't. It's part of normal medicine. It's part of humanity. It's part of people. And that's what we do.
Dr. Feldman, thank you so much for being with us today. I really appreciate it.
Okay, welcome.